Thank for everyone who joining to our basically first webinar for the dentist in India. Before I let Sarjit to say a few words, I would like to introduce myself. My name is Oz Wartenberg. I'm the CEO of the company called Simple, an Israeli company. Basically, we have two products, two families. One of them is with the name Ovalis, and the other one with the name Smart. Today, we are going to focus on the smart system, and I wish interesting lectures. Then again, thank you everyone. Sarjit, please take it from
Yeah,
here.
yes. Very good afternoon to all of you. It's a pleasure to have this kind of lecture. We are coming up with some very innovative implantology products. One of them is smart implant, which will be a next big thing in Indian implant practice. And as I can see, we have some very good implantologists who have joined our session. And from here, in this lecture, we have Dr. Yo, we have Dr. Himang Zala, and Dr. Rahul Shah, who will be sharing their views about our brand they have used and what to say. Let us start, folks.
Okay. Doctor, basically, as Sarjit said, we have three lectures, and we will start with Dr. Yoav Leiser, and each one of them will introduce himself. Please, Yoav, you can start.
So my name is Dr. Yoav Leiser. I'm an oral and maxillofacial surgeon from Israel. Finished my dentistry and then did my PhD in molecular biology. Then later on, I did my internship in maxillofacial surgery in Haifa, in Israel, and finished my MD as well in the Tel Aviv University. I've been doing for the past 20 years dental implants in all types, and I know Oz for almost the same amount of time that I'm doing implants. And he came to me around a year or a year and a half ago, talking to me about a new implant, a new concept of an implant. And I was very excited and I started doing it. And I want to share with you my knowledge and my experience with this type of implants. So it's a simple and smart way in dental implantology. I will first try to explain, introduce a little bit the implant itself, the logic around it, then the indications for using it according to my experience, simple examples for things you can use using this type of implants, because I think the sky's the limit, but you have to understand that everything that is new takes time for people to really master it. And I will show you a little bit of complex cases as well. And finally, some tips and takeaways that you can take and do it in your clinic. The good thing about this type of implants is that they are not really that hard to do. So they are basically, you don't need a very steep learning curve because they are very simple. That's the name as well. But it's a different concept. It's not the same as doing normal implants. So the mechanism around this type of implant is osteodisplacement, which means that you take the bone from one place and displace it to another place in order for you to be able to sinus lift, closed sinus lift without adding bone and by using the normal autogenous bone of the same person. So this is osteodisplacement. And the implant doesn't look the same as normal implants. You can see on the left here all the type of implants that are present according to internet. And the implant on the side, on the right side, is the simple or smart implant. And you can see from the start that it's not a simple implant. It's like a tool. It's more complex. So half of it looks like a normal implant and the other half is a tool. a specialized tool for you to use if you want to do any type of procedure, but I will show you some examples later on. But especially if you want to do closed sinus lift and to displace the bone from the sides to the apical part of the implant in order to lift the sinus. The implant uses a system that is called Archimedes screw, also known as the Egyptian screw. It is one of the earliest documented hydraulic mechanism. Archimedes first described it in around 234 BC, and it is a reversible hydraulic machine that can be operated both as a pump or as a power generator. In our case, we are using it to displace the bone from the sides. By going forward, you're displacing the bone apically in order to lift the sinus without really interrupting the bone from the side. So the good thing is you can use it for areas where you were before that were unsure if you can do it. For instance, contraindications for sinus lifting. If you have an infection and you don't want to go into the sinus, you can use this type of implants in order to displace the bone without really going into the sinus itself. So it's a simple but very smart implant. As I said, the apical part of it is a Archimedes screw, and it's specialized for closed sinus lifting without the need for bone grafting or extra drilling. You can also use it for contraindicated cases, as I will show later on. And you need minimal drilling, not more than 1.5, 1.8 millimeter, that's it. And you're transporting the collected bone forward to the process, to progressing the implant as we go along. I will show you the concept. So one thin drill and then manual insertion. I'll show you a video now for the understanding what we are talking about. So the first thing is just watch the video and then we will try to explain it later on. So as you can see, when the implant is going forward, the bone from the sides is going forward as the Archimedes screw pushes it forward. So when you're lifting the sinus, you're lifting the sinus with autogenous bone and not with metal. And if you want to see it live, the first thing you do is drill a 1.5 millimeter, very small drill, because you want to use as much bone as possible. You drill all the way to the floor of the sinus. Then you take the implant. Everything is done by hand, so it's easier. You can also do it by machine, of course, but I would prefer to use it by hand. And then when you start drilling by hand, you cause the bone from the sides to enter and then displace apically. Eventually, the contact in the Schneiderian membrane and everything else is done with autogenous bone and not with the metal itself. Later on, the implant really knows how to adhere to the bone, and there is a very good stability. And there we go. You can see here in a video on the side, so you can see how the bone, or in this case, something that imitates a bone, you can see how it moves forward by using the drill and just using the implant as a drill. So when you try to put it in, you can see all the bone from the sides is going forward and moving with the implant itself. By using the implant, you displace the bone forward. And if you want to understand it, it's because when you're doing the insertion of an implant, you're using clockwise rotation. but the Archimedes screw is in a counterclockwise. So instead of going inside the bone, it displaces the bone forward. As we said before, it's an Archimedes screw. And if you want to see it from the sinus, so-called, you can also see it from a different angle. So you can see that the bone is moving forward and you don't see the implant at all. You just see displaced bone going forward and going into the sinus. We are looking from the sinus to the implant. And you can see that all the bone is displaced and moving forward as the implant goes in. And there you see the implant a little bit. And if you were doing it live, all this bone that was displaced forward actually helps you for the sinus lift augmentation. What about the membrane? So you are afraid because you have a new implant, you don't really know how the membrane reacts to this. So importantly, the edge of the implant is not really sharp. So if you do it slowly, without going into the sinus by mistake, you can see when you're imitating a membrane in the lab. This is a PRF that imitates a membrane, Schneiderian membrane. You can see that when you enter the sinus, it does not, even though it's moving, rotating, it will not tear the membrane. So it's moving, but it's not tearing it. So it's also very important and gives you a lot of safety. You can still move it without tearing the membrane or the PRF itself. Okay, so I want to share with you some of my experiences with these type of implants, and I will show you a standard closed sinus lift without hammering, without anything. I will follow by standard implantation after failure of Kalt-Veluk procedure. Kalt-Veluk is a procedure when you're doing cleaning of the sinus due to infection or antral fistulas, etc. In most cases, after you're doing cleaning of the sinus using Kalt-Veluk, it's contraindicated for standard implantation by sinus lifting, open or closed. But in these situations, as we are not really touching the sinus membrane or we are just displacing bone, we can safely do it, and I will show you an example of it. I will show you another case of a patient that had a really large cyst or tumor in the upper jaw, and we had a very small amount of bone that was created. So in order to preserve the bone and displace it correctly, we used it for osteodisplacement and creation of new bone on the sides. I will show you another example. And mandibular nerve bypass, which is also something that can happen in some cases. If you have enough thickness of the mandible, you can also, because you're not really drilling and you're not really changing the size of the drill, it's only 1.5 millimeter and that's it, and you don't have a really heating problem. So when you're very close to the mandibular nerve, you can use it as well. Again, as I said, it's not just for sinus lifting, but most of the specialization is for closed sinus lifting. So how do you insert your implant? So it's a different implant, as we said. So you have different system to understand it. And I will show you an example. So in this case, this patient needed 4 implants at the back. We could do a closed sinus lift or an open sinus lift, depends up to you, on the back. But in this case, we're going to use 4 simple implants, smart implants on the back in order to displace the flow of the sinus. As I said and I showed, first of all, you drill 1.5 millimeter all the way, the same as closed sinus lift, only 1.5. 1 is also okay. It depends on you, of course. And you drill it up to the floor of the sinus. Then you use your implant to start lifting the sinus floor without tearing the membrane and displacing the sinus, the bone from the sides to the apical area. We're doing normal insertion, which means clockwise rotation, even though the screw is counterclockwise. So again, as I said, this is a different system a little bit, because we are speaking about the height of the amount of bone that is left for sinus, closed sinus lift. So this is the H on the right side, on the lower right side, you can see it. And in here, it's called the B. B means fixation portion length. So you choose your implant. Every implant has the diameter and the length as normal implants, no difference. The only difference is the amount of residual bone that is left in order for fixation. So if you have around 7 millimeters left, you can use a 7 millimeter by 11.5 length and 3.5 wide. Or you can also use a 375 or a 4.2, it depends, up to you. So if you use a 375, a normal implant with 11.5 millimeters length, and you have a residual bone of 7 millimeters, you will choose this type, number 3. But if you have less, like 3 millimeters, for instance, you will choose 6. So the amount of residual bone that is left is the choice you do in the B section column. So this is the only difference in the implant. All the rest is the same. So only fixation portion length is the only difference. And again, we try to see it on the CT scan and to understand how much bone we have left. And with that, we choose the right implant for the job. So the procedure. I'm going to show you 2 small videos of a surgery that I did, so you can see a little bit. I'm sorry for the quality. It was done in the clinic, but you can see the drilling, the first drill. On the right side, you can see the drilling of the implant. This is the 1.5 or 1.8, depends, up to you, depends on the quality of the bone that you are using. You're just drilling very slowly, and you try not to enter the sinus. Then we're taking the correct implant that we want to use. In this case, we mount it on a buxa, on a handpiece. And then when you start entering the sinus, it gathers all the bone from the sides, and then it fixates on the other part, which is the screw part. And then you can set it in. Try to move slowly, and basically more rotation than pushing. So if you push too hard, you might enter the sinus, so you have to really use it for rotation. And this is another example, another implant. Again, first of all, you drill it. The amount of drilling depends on the sinus, of course, and on the CT scan. Then you take the corrected implant, the one that you wanted to choose. In this case, you can see it. This is the implant. Then you can put it in and start rotating to the right. Normal insertion. And then it gathers all the bone from the sides and enters the sinus without any problems. So this is basically nothing really different except for the implant itself, and a little bit about the procedure. And I will start showing you examples of cases that I did. So this is a patient of mine called Malka. She was a healthy female. She had, you can see, tooth number 17 with really large periapical cyst, and tooth 16 was missing. The plan was to extract tooth number 17, clean it, curettage, bone graft, and standard implantation. So in this case, we're using normal implants, regular implants, whatever you've got. And in area 16, we're going to use a 1.5 drill and then manual insertion of smart implant into 11.5 millimeter length. So we're going to lift the sinus. So the procedure, the first thing is to extract the tooth in the back, which is number 17. After extraction, you have to clean. This is the normal way, and you expose the area that you want to drill with. This is after the extraction and the cleaning. The first insertion is the normal implant. In this case, it was a 5 millimeter, but by 11.5. Then we use a 375 by 7 and by 11.5. 7 is the amount of residual bone that we want to adhere to. So this is the implant. This is the way it looks before the insertion. And you can see the insertion and the implant is inside. Then bone grafting, normal bone grafting. I'm using human bone grafting in this situation, and close everything up and wait for the same amount of time. Usually it's 6 months. So this is the amount of bone that we had, around 7.5. So we choose a 7 millimeter residual bone implant. And this is the implant. And if you look correctly, you will see the sinus membrane and the amount of bone that was gathered without bone grafting, okay? No bone grafting was added. So you can see the amount of bone that was displaced by this implant itself. Another example, I will show you this because it's important. This case had a failure of a normal implant. Then in failures, you want to be safer and don't go into a sinus that is already diseased. So it's important example. This is Rosine. She was a healthy female. She had a tooth number 26 with large periapical cyst with odontogenic sinusitis, sorry. The plan was to extract tooth number 26, curettage, use a Caldwell-Look approach to clean the sinus. And as we said, when you're cleaning the sinus, you're destroying part of the membrane, and eventually, if you try doing an open sinus lifting, it will fail. Even a closed could fail. So, followed by standard implantation, it was a failure, of course, because there were too much damage and too much infection. So she came to me, we waited 3 months, and we used the simple implant instead of the regular implant. And as I said before, you can see the case. This is 26, tooth number 26 with the big periapical lesion. You can see it on a CT scan. It could erupt, it could not. In cases where you look at the CT scan, less than 0.5 millimeter thick of bone, you won't be able to see. So I don't think there is any spillage, but it could. It's only in the clinical situation you can see it. So you see the amount of residual bone. So the first time we just did a normal implant after cleaning the sinus. So this is the normal implant after 5 or 6 months. You can see bone was not created, only in the apical part. And when you look at the CT scan after you extract the implant, you can see that there is something over there. So I wouldn't go and do another sinus lift when there is bone here that I'm not sure about. So this bone is not really a good bone. Maybe it's an infection. We don't really know. And I don't want to go into the sinus and start cleaning it. So, because again, it's a contraindication. So if I have 7 millimeters here, I can use this type of implant. As we said before, you can see it displaces the bone. So the normal bone around on the sides of the insertion will apically displace and move everything that is here apically. So I won't really have a contact with this type of infection or something. So something is there. I don't want to use anything but a normal implant. In this case, we don't even want to open, so we're using a flapless procedure. So just drilling and then displacement, and the implant is in place. So in this situation, the implant can't really hurt the membrane, but it won't even reach the membrane. So most of the bone will be protecting the implant, the normal bone. Another example, this is a patient with a large tumor. He had a cyst, periapical cyst that lost most of his maxilla, and he had a minimal bone for implantation. So he was a healthy male. His name was Dvir. He had a large infected odontogenic cyst. Following removal and bone grafting, there was a very thin bone left in the maxilla. And again, thin bone, I can displace some bone and maybe create bone as well. So the plan to do 2 implants at position 25 and 26, closed sinus lifting, minimal sinus tissue exposure, and rehabilitation. So this is the cyst. You can see in the CT how large it is. If you look a little bit further, You can see that it's a very large destructive cyst. And in this situation, after you extract the cyst and then you clean everything up, you end up with a very low quality of bone. So this is the amount after extraction of the cyst. So you can see that the bone is very, Hansfield units are very low, if you understand Hansfield units. So the CT scan shows you that the quality and the density of the bone is very poor. You can see it also in the cuts. So you can see that the cuts show you that the quality of the bone is very low. But again, you can use implants that take the bone from the sides and displace it to the apex. So for the procedure, we did a simple implant insertion and push the bone using new bone collected into the sinus. So you can see the exposure. This is before the cutting, so you can see that the soft tissue is already scarred after many operations before and this is after you expose. You can see that the bone is in poor quality. We use a 4.2 by 10 millimeters and 5 millimeters of residual bone left. Then we do the drilling, and this is the implant. Then we put the implant a little bit lower from the bone surface in order to get as much stabilization as possible, and close everything up. Again, it's a much scarred area. You can see before the quality and the amount of bone that we had, and you can see almost the implant really stretched the bone all the way up to the apex of the implant and created new bone after half a year. And this is the patient after the final reconstruction, almost half a year already, and everything is okay. I'm sorry I don't have really long follow-ups. Everything is new also to me, so you have to be patient with me. Another situation that happened during the year and a half that I'm using is a patient that arrived with very small amount of bone in the mandible, but he had a good thickness. So I wouldn't use a normal implant, but I could use this type of implant since it will not harm or hit the nerve. It will not even do anything except for the displacement a little bit. So you drill a little bit further, and we'll show you an example. So Chaim was a healthy male. He had mandibular posterior and anterior insufficiency, the maxillary posterior insufficiency as well. So the plan is to do extraction, total clearance, 4 simple implants in the posterior mandible, lateral to the mandibular nerve, to extend in the front for regular implants and immediately load the case. So the patient will receive teeth in 24 hours. I'm not talking in this lecture regarding immediate loading, but I have a lecture for that. If there will be any interest, I can also do that. So first of all, I'm talking only about the simple implants. In the posterior maxilla, smart implants in the sinus for sinus lifting, closed sinus lifting, and insertion, 2 on the left, and I think 2 on the right. I will show you an example of the pictures 1 minute ago. So this is the patient. He arrives with a removable denture, and all the teeth were suffering. You can see how much infection in the lower part. The upper part wasn't so aesthetic, but he was happy with it, and he didn't want to change, so we only used the back, the posterior maxilla, and the lower part, the mandible. So you can see how much infection this patient has. And you can see the amount of teeth. All the teeth should be extracted and cleaned. You can see how much infection all the way to the nerve. And you can see the amount of bone on the buccal part. So you can see that you have also very nice thickness. So the nerve is very close to the edge, but you can and you could use an implant on the right side. So it's a very sophisticated technique. It's very dangerous. You wouldn't want to do it in a 3.8 or 3.2 millimeter drill, because you might hurt or hit the nerve. But if you're doing a 1.5 very close to the edge, and you're using an implant that also a little bit displaces bone and creates its own path, this is a better option. So using this type of implants, it's 3.5 millimeter in diameter, 11.5 length. And you can see everything is buccal to the nerve. And in this case, we can't use a hand piece. So you either use a ratchet or a mechanical drill. This is the surgery. And this is the immediate loading. You can see the teeth that he received after 24 hours from the surgery. And you can see the implantation. So you might look at it and say, oh, this is the nerve. Yes, this is the nerve. You can see it in both sides. But we are lateral, and there is no damage to the filling in the lower part, the mandible. And you can see that I drilled a little bit further, a little bit more than what is needed, because all the displaced bone will reach this part. So I want to find a place for her. So when you're doing sinus lifting, the bone goes displaced to the sinus. But in this situation, you don't want to compress it. In the upper part on the right side, we did a normal simple implant for sinus, closed sinus lifting. And then on the left side, maxilla as well, both implants. So you can see the bone reaches all the way to the sinus floor, and you can see the sinus floor here and the bone around the implant. He already did an immediate loading, so we did 6 implants immediate loading in the front, and we are waiting for the posterior implants for reconstruction that will come in a couple of, I think, months. He has around 3 months left to finish everything up and reconstruct. So this is the final picture. The final case that I wanted to show you is a very interesting case, because this is Alice. She was a healthy girl, very good looking one, and she had a maxillary posterior insufficiency. And also she had an orbital fistula on the left sinus. So she came to me, and we are doing this type of implants, this type of treatment for orbital fistula by combining ENT and maxillofacial surgery together, so in the same operation. So the ENT did the FES for cleaning all the sinus, opening up the osteomeatal complex and everything. And he also did a septal deviation procedure. And when he took out the vomer, I said, okay, I want to use this type of bone. The vomer is the bone in the midline of the nose. So he was taking the bone out for the deviation of the septal treatment. And I took the vomer from him, and I used it for the sinus floor on the left side after the procedure that I did, which was cleaning the sinus. So I was cleaning the sinus, and then I grafted the vomer, the bone from the nose, into the sinus floor. So to get a good amount of bone, because I knew I wouldn't be able to do a sinus lift. So in this situation, I had 4 implants that were needed to be reconstructed on the right side, and I did normal closed sinus lift. And on the left side, I did 4 implants that were compromised area, because there was already a cult veluk and vomer bone grafting. So I used specialized implants with the simple implants, so I can really compare. So it's a good option to compare, which means I can really see the difference between normal sinus lift on the right side versus simple implants on the left side. So this is the patient. You can see the problems that she had. So on the left side, you can see already after the cult veluk treatment, this is the vomer that came from the midline of the nose. After, you can see it was here, around here, and we put it here. So we had a good amount of bone that we used for sinus lifting. Again, the sinus is already treated, so I wouldn't go and do sinus lifting procedure, but I can do simple implants and put the bone and displace it. And on the left side, on the right side, I had a broken tooth, because she was a parafunction patient, and on here as well, with a lot of infection in the apex. So in this situation, we extract the teeth, we do simple normal implants, 4 normal implants, and on the left side, smart implants. So right sinus lift with extraction, the procedure is not the topic of the lecture, but we did the extraction in both sides, an implant here, here, and here. You can see part of them. And on the left side, this is the main talk. We do specialized implants, the simple, smart implants. You can see the insertion, very simple one. All the bone was in good quality. The Vomer was a very good option for bone grafting. All the implants are in place. The patient goes home. And then after half a year, we did the panoramic view for the procedure. So you can really see that these are normal implants that we did closed sinus lift. And on the left side, we did 4 specialized implants for sinus lifting as well. And you can see the procedure is basically the same. So both have good quality of bone around them and good for reconstruction. Unfortunately, she is not ready for reconstruction yet, so she's waiting by itself, but we finished the time for waiting. I will show you later on, if I have more lectures, the results of this situation, which is very nice to see, but all the implants were okay. So a little bit of take home messages. So smart and simple way to deal with sinus lifting without the need for bone grafting. You displace the bone forward or apical and without going into the sinus. So it's a very good for compromised cases when sinus lifting is contraindicated because you're not really going into the sinus. You're using the same person's bone in order to displace it. And this is the thing that reaches the sinus itself without going into the sinus itself. But if you do, you won't be able to tear the membrane if you're not too aggressive, as I showed you in this lecture. When you have tumors or cysts surgeries and the bone is deficient, especially if you have very low quality of bone, you can really condense the bone and displace it forward. And at the end, you can see that the bone really stretches through this type of implant. And also, it's an option. It's not really 100%. I wouldn't use it all the time, but if you have a very small amount of bone in the buccal area that is enough for an implant, you can bypass the nerve by using minimum drilling, minimum heating, and only manual insertion of the implant, and you preserve the nerve and also been able to reconstruct this patient. In other cases, I wouldn't be able to reconstruct him completely. That's it. Thank you very much for listening. I hope you enjoyed it. And if you have any questions, I'm open for questions.
Okay, perfect.
Okay.
Yeah, so hi friends. We have seen an amazing presentation with out of the box thinking. So what we are going to discuss here today is absolutely out of the box thinking for any implant solution, specifically to maxilla in the posterior region where sinus is a major problem. Having said that, I have not much experience. I have used limited number of implants, and I have one complete case which I have carried out in last 3 months from placement to post-op and loading. I have had amazing results, and I would like to just share what I have experienced with this particular system. So, next slide, please. Oz, next slide. Can you hear me, Oz? Yeah. So I am Dr. Rahul Manasha, an oral and maxillofacial surgeon. I practice in India in a city called Thane, which is very close to Mumbai. I have had an experience of using various implant systems, must have placed about 5,000 implants, but I have never come across such a unique design of dental implants, which can probably be placed as a very innovative thinking by the designer, where they have used the concept of osteodensification in the implant itself. So I'll just take you to the journey of my one single case, which I have done. Next slide, please. So we currently are aware that for any kind of axillary posteriors where the bone height is deficient, we carry out either indirect sinus lift or we carry out direct sinus lift. As an experience, generally in the maxillary posteriors, width is not a major concern. It's always the height. And with time, we have come to know that sinus is a deterrent, but it's a very good friend, as in it is very amicable for grafting. And we have been using these conventional techniques for more than 25 years with adequate or I would say clinically acceptable results. But next slide, please. But today I'll try to introduce you all to something unique, different, and in my way, it's magical in its own way. Next slide. It's the smart implant solution, a simple graft-free technique wherein the shape of the implant has been designed such that its tip itself causes osteodensification. So when you see it, as you ratchet the implant apically, the because of the reverse pitch of the implant, the bone in that region is automatically pushed up. Secondly, as you can see in the video, this is a single drill technique and the implant is very active in its coronal 5 millimeters. So an average, if you see in most deficient posterior areas, we generally have residual bone between 4 to 5 millimeters. So the design has been made in such a way that the lift happens beyond this 4 to 5 millimeters. They have 3 millimeters beyond, 5 millimeters beyond, depending on your available primary bone. As you all can see in this simulation, as we ratchet the implant, the bone around these threads are pushed along with the implant, specifically in its apical end. When we do a sinus lift, we pack the whole volume so as to make sure that the tip stays within the bone. The bone around the apical end is actually of not great need in terms of stability of implant. What I mean to say is the volume which we add in direct sinus lift is to compensate for some amount of resorption, and also in implant placement we will have implants placed ideally in the bone. Next slide, please. This is a particular case. This is a patient which had missing upper right 5 and 6. 4 was an implant placed. This was referred to me at my practice. Next slide. I have used dynamic navigation as a technique to perform this surgery because one important aspect which was covered in the previous lecture is the drill has to be made sure that first drill which we use does not puncture the sinus floor. We have to use the implant like, for example, a densa birth to push the little bit of cortex along with the native bone to be placed up. So if we pierce with the first drill, then this technique is of not great use. Someone's mic, can someone mute it? Yes. So this is a video with dynamic navigation. A single drill has been done to push the bone up to the floor of the sinus, and then the implant has been ratcheted beyond its depth. You can use freehand with bone stoppers for your drills. You can use your experience to make sure you do not overdrill. You can use guided surgeries to perform this primary osteotomy, or you can use dynamic navigation. In any situation, the aim is not to pierce the sinus and then ratchet your implant. Next slide, please. This is the diameter and length of implant I have used. We generally talk for dental implants with diameter and length. In this, they have diameter, they have length, and they also have one more length which is beyond the turns or beyond the threaded area. Next slide. This was the implant placement with dynamic navigation. If you can see in this particular case, there is deficiency in width as well as height. Next slide. This was immediate post-op IOPA. Next slide. This is the pre-op CBCT showing the deficiency of bone. The primary bone in each region was about 4 and 5 approximately. Next slide. Now is the fun part. If you see in the bottom two images, there is a good amount of bone which has been lifted with the implant. There was no indirect sinus lift done, no osteotomes used, single drill, and then the implant was ratcheted in its place. Next slide. To show immediate post-op is okay, but what happens to this bone after 3 months of consolidation? This is the CBCT post 3 months. You can see good primary bone formed around the implant in 360 degrees. Next, please. So this has been my experience with the smart system. Hope every one of y'all are up to trying this new technique and then give your opinions as well. Thank you.
Okay, Dr. Shah, thank you very much. If there is any question, then you can ask it now. If no, I think that we should move forward to the last lecture, which is Dr. Zala. Dr. Rahul Shah, thank you very much for joining us and share this case and experience. Thank you very much. Okay. Dr. Zala, can you hear me?
Yes, I can hear you.
Okay, the stage is yours.
Yeah. Uh, can you allow me to share my screen?
You cannot do it.
Just a minute.
There is on the bottom bar.
Right. So,
Okay,
can you see my screen now?
I can see it.
Yes, yes. So I am just giving a small presentation about narrow reach. My previous two doctor colleagues has already given uh, the presentation about challenges which we face for deficient height. But now I'll just show a small presentation about deficient width, where we have very narrow width or there's less dimension for bone to place the implant. As we know that we need at least 1.5 mm, both buccal and palatal or lingual to the implant. So if we see the alveolar reach, the minimum alveolar reach which we required is around 5 to 7 mm, and below it is, we can say, is a deficient alveolar reach. And if there is less than 6 mm, we cannot place a 3.5 mm or greater diameter implant. So we all know the different techniques. We know the densification, ridge state, and everything. But we are going to discuss about a newer technique. Now I'll just show you a small case. This case, it looks very good for the missing upper left 5, or we can say second premolar. But when we see the OPG, we can see the good amount of length available. And when we see the width is very compromised. It's around 3.6 or even less, and it is straight. So it's more a severe class 4 type of the deficiency for the rich split also, and it's very challenging case. So how we can do in a smarter way. So normally I like to reflect the flap. I don't like to go flapless because I want to see the final outcome. I have reflected the flap, both buccal and lingual. I place a primary pathfinder drill, which is 1.5 to for the implant, and then I took the tool, which is most important for this treatment, which is the implant itself. You can see this tool, it comes with the mount, uh, and it has two distinct part in it. The first part we can say is the osteotome portion, and the second part is the fixation. Right, osteotome portion helps us to displace the bone and which will not create dehiscence. And the second part is the fixation part, which is like normal implant part with the thread screw, which will help us to get the primary stability. So how we do the implant is just after the path file or path drill, I just gently push the longitudinally and with the hand tool uh, less than 15 RPM. So we allow the bone to absorb the force and very gently push the implant at the same time inside the osteotomy prepared. So it will slowly and gently expand the bone. Now, if you see this video, this is a live video. After first osteotome part, we allow the bone to relax little bit. We remove the mount, and then after a while we use the implant driver and again slowly and gently push inside and allow the bone to absorb the area. So the moderate longitudinal force concurrently is very important over here, because if we do not give a proper longitudinal force, there is chances that implant will spin at that place instead of going inside. So you should give a moderate longitudinal force while pushing the implant inside, and after every 2 to 3 mm, it's ideally it should stop, and we should allow the bone to absorb the force, right? And then this is the final part. Again, I will check everything, the angulation, everything, and then slowly again and gently will guide the implant to its final position till the rest of the bone. And once we feel everything is okay, only with the single drill, you just see the implant is nicely placed. We can see the buccal bone, which is been expanded and well preserved. So over here, the patience and preservation is the key. And this is a post-operative X-ray, and the healing abutment and the final switches. This is post-operative healing. So I have kept my presentation very small, and this is just to demonstrate how the implant should place and how it works. It just displays the bone, and if this is the narrow ridge, and this is how the implant will push the bone and the buccal and the palatal side, and you can preserve the bone and place the implant in this type of narrow ridge. Um, Again, thank you so much for listening me. This is a very quick demonstration. Could you hear me or?
Yes, yes.
Yes.
Eh,
So, right.
it was very impressive, Dr. Zala.
Thank you so much.
Really, it's amazing to see how narrow the ridge was before the procedure, and the buccal width after. Very impressive. Again, if there is any question in general to Dr. Zala or about the system, this is the time for asking question. If there are some, then please go ahead.